Now let's talk about iron deficiency anemia. This is a very important topic from the hematological point of view. This is the most common hematological disease of infancy and childhood, and most of the cases are caused by dietary deficiency of iron. If we do not give enough iron containing food to the child, then this can happen. Especially malnutrition is the important cause. The susceptible age group regarding pediatrics are preschool children and adolescent because they are rapidly growing age group, preschool children and adolescent. Another important point is they preference certain type of diet, and that diet may not be rich in iron. That is another important cause. Now, regarding the normal iron physiology, we have to talk about that before we enter into the pathological aspect. What is the total body iron content in us? It is about 5 gram in adult versus zero point 0.5 gram in a newborn infant. So newborn infant has got a very less amount of storage of the iron. And to maintain the positive iron balance, we need at least 1 milligram of iron absorption per day. Whatever iron we take in our diet, only 10% of the iron is absorbed. Remember that. But we don't need that whole amount of iron. Just 1 milligram of iron is enough, okay, uh, per day to maintain the positive iron balance. So we're talking about the normal iron physiology and the sources of the iron in case of children. So see there, iron is very commonly found in meat products like different types of meat, okay, any type of meat, liver, kidney, egg yolk, also found in green vegetables and fruits. So if we give a balanced diet to our kids, then there will be enough sources of the iron. That's the important point. Balanced diet is the important thing here. And regarding iron in cow's milk and breast milk, one of the questions which is asked to the pediatric student, though breast milk iron is slightly lesser amount than cow's milk or the formula milk or formula feeding, whatever, but the bioavailability of the breast milk iron is the excellent one. So it is compensating in that way. And one other point, if some child is only fed cow's milk, remember some family believe if milk is given in a good amount, then no other nutrition may be necessary to this kid. That is a wrong concept because the cow's milk iron is poorly bioavailable, and that itself can lead to iron deficiency anemia in a period of time. And then if the child only takes milk, there will be no appetite left for other nutrients to intake. So this is not a good habit to develop. So we should give milk. There's no doubt about it. In a growing child, milk is very necessary, but not only milk. Okay, it should be a balanced diet. Now, regarding the iron distribution in hemoglobin, 65 to 70% of the iron, okay, is there in the hemoglobin in our body, as a ferritin and hemosiderin around 20 to 30%. These are the storage form of the iron. Hemosiderin, okay, it's called the iron pigment. It is also considered one of the storage form of the iron, and the remainder is present in myoglobin and hemenzyme. These are some other substances where iron is also present. Myoglobin is just like hemoglobin, which is present in the muscle, also in the heart. Myoglobin is present, and it acts as a oxygen carrier or transporter there. Now let's move further. We're talking about some very important aspect of the physiological aspect before we go on to the pathological discussion. How iron is absorbed and regulated in our body. So iron absorption primarily occurs in the duodenum. Duodenum, it's the first part of the small intestine where iron absorption occurs mostly. It also occurs in the jejunum or ileum, but major part in the duodenum. Readily absorbed in the ferrous form. There are two forms of the iron, ferric and the ferrous. Ferrous and the ferric. Okay. Now ferrous is the reduced form, ferric is the oxidized form. So ferrous form is much better than the ferric form for the absorption of the iron. And another important point I like to highlight here, the iron which is present in the meat or from the animal source, the iron is present in the ferrous form usually than the ferric form. That's why that iron is more readily absorbed than the iron which is available from the plant-based food. Now, absorption of the iron is enhanced by vitamin C or ascorbic acid, glucose, fructose, and some other amino acid as well. But important thing here is vitamin C. Vitamin C is, a very important, type of vitamin which enhances the absorption of the iron. So if somebody is iron deficient, we can promote, vitamin C intake along with the food. And what are the sources of vitamin C? Yes. What are the sources?
Citrus fruit like lemon,
Lemon.
Like so, the lemons, orange, these are like citrus fruits that
orange.
readily available vitamin C.
Excellent. You just say citrus fruit and your teacher will be satisfied with your answer. Excellent. Citrus fruit like lemon, oranges, and those type of fruits, they are abundant source of vitamin C. And so it really helps in the absorption of the iron. Now, absorption of the iron is inhibited by these certain substances like phosphate, tannin, calcium, and bicarbonate. The important here are tannin and calcium. Tannin is present in the tea, in coffee, like those things. So if somebody is iron deficient, we don't advise them to drink more tea and coffee along with the food. Iron absorption, is done by mucosal cells, and they bind with apoferritin to form the ferritin. This ferritin is the storage form of the iron. One very, very important point here, these mucosal cells can regulate the amount of iron absorption. If our body is already deficient in the iron, then there is increased absorption of the iron from the food. But if there is abundant amount of iron already present inside our body, then the absorption which is occurring in the intestine is controlled by the mucosal cell. Never forget this important concept here. Now, let me quickly give you one scenario here. In case of thalassemia major or beta thalassemia major, there is excessive iron overload in the body. One of the source of iron in that condition is excessive GI absorption. Excessive GI absorption. Now, why is that? Already there is too much iron in the body. Why? Because of the hypoxic environment produced by that condition, the body, the mucosal cells feel I still need to absorb more iron, and that is the mechanism. In a state of enhanced iron absorption, iron entering the mucosal cell is delivered directly to the plasma. Sometimes it may not also need any transporter there. And in plasma, iron is bound to transferrin, which is called transfer or transport protein. And then it is transported to bone marrow for use or for the storage. Let's move further. These are the important points. Now, all of you, please focus here. This is also, the concept about the normal iron metabolism in our body, how it happens. You see that we are taking food, and our food has got iron definitely. There are two sources of iron. One is heme iron, another is non-heme iron. Or in other word, this is animal source iron. This is plant source iron. You can also remember like that. So this is a rough estimate of iron concentration in our diet. If we take around 1000 kilocalorie of the food, then probably 7 milligram of that food contains iron. But this is a rough estimate, It may be more or less than that. Out of that, less than 10% of the total iron is only heme iron or ferrous form of the iron, whereas more than 90% of that iron is non-heme iron or ferric iron. Now, look at the important point here. This heme iron is readily, available for the absorption, whereas non-heme iron is difficult to absorb. That's why I kept on telling this point here. In case of iron deficiency state, we should promote the heme iron to our patient. These are the stimulator for the iron absorption, like amino acids and vitamin C. and these are the inhibitor like phytate, tannins, and phosphate. After it is absorbed mainly from the duodenum. Okay, uh, it will enter into the blood. In anemia situation, in hypoxia situation, and when there is decreased iron store in the body, the amount of iron absorbed from these intestinal cells is maximum, already talked about. It may reach even up to 3.5 gram per day. Okay, and that is too much iron absorption. Now iron is stored as the ferritin form. Okay? It is transferred as a transferrin form, and iron is stored in a different form in our tissue like hemoglobin, ferritin, myoglobin, and even heme enzyme. Now with this physiological aspect, let's talk about what are the causes of iron deficiency. Very, very important question in the exam. Now first, when there is a diminished iron store in the baby, okay, there is a high chance of iron deficiency anemia. And the explanations are low birth weight baby. The size is less than 2.5 kg. So probably they have decreased iron store also. Twins, okay. Twins means there are two babies in the place of one. So everything is divided between them. Okay, one baby may be slightly bigger than the other, and the amount of iron stores is also divided between them. Okay, so there is a high chance of diminished iron store. Early clamping of the cord, we have discussed this in obstetrics. There is a practice like that in some of the centers, and in some other center, okay, they don't. Yes.
Sir, excuse me for a minute.
Yes, yes. What happened?
Basically, sir, Sir Irfan cannot connect. So, sir, please allow me for recording so that I can forward to management. Sir Irfan just texted me cannot connect. So, please allow me for recording.
Sure. Wait. Sure. Okay. I think I've done that now.
Yes, sir.
Yes.
Thank you, sir.
Okay. So see there. So please focus back. So what I was talking is there is early clamping of the cord in some of the centers. In some other centers, there is a delayed clamping of the cord. Now, regarding the storage of the iron, delayed clamping of the cord is better than the early clamping of the cord because we allow some more blood to go to the baby's body. Okay, so that is a good practice to do regarding the iron store. But if some medical centers or the delivery centers are early or clamping the cord quite early, then probably the baby, especially the low birth weight baby or premature baby, they will be deficient in the iron. That is the one of the factor. Hemorrhage from the cord or placenta. Okay, hemorrhage from the cord or placenta during delivery is another one. Now, there are different terms which you have already learned from the obstetrics. Antenatal hemorrhage is one of the term which is used here when hemorrhage or bleeding occurs prior to the delivery. And sometimes even during the delivery, before the separation or birth of the baby, placenta bleeds, then there will be decreased blood flow towards the baby, and that may be a cause of iron deficiency anemia. So this is the first cause, diminished iron store. Let's move on. The second one is diminished iron intake. Now, feeding with cow's milk. So already talked about. The concentration of iron is a bit less in cow's milk, and more important than that is poorly bioavailable. And third one, if they only feed cow's milk or drink cow's milk, then it will suppress the appetite, and the baby or the child may not take iron-rich food. Another cause may be blood loss from the body. Hookworm infestation, portal hypertension, and rectal prolapse. All of these will cause blood loss from the GI tract. Okay, blood loss from the GI tract. Regarding portal hypertension, okay, sometimes there is formation of rectal varices, okay, which are also known as hemorrhoid. So that may be the cause of prolonged blood loss. But rupture of esophageal varices usually doesn't lead to iron deficiency anemia. Okay, because the blood loss is massive there, and it usually leads to normocytic normochromic anemia. Regarding the hookworm infestation, we have already talked that before, isn't it? It's a very important cause of anemia in the developing country. especially towards the rural area or village side, where those kids, they do not wear any slipper or shoes. Okay, they walk barefoot, they play there barefooted, and if there are, a larva present regarding the hookworm on the soil, then that larva can penetrate through the soil and goes to the blood. This is how hookworm infestation occur. Another is diminished iron absorption from the intestine, which is seen in malabsorption syndrome, like celiac disease. When there is increased demand of the iron, there is high chance of iron deficiency anemia, which may be seen in low birth weight baby and during puberty, or you can say during adolescent age. The demand is high, but if supply is not according to the demand, then there is a high chance of iron deficiency anemia. Another is errors of iron metabolism, like sideroblastic anemia and atransferinemia. Sideroblastic anemia means the red blood cells cannot utilize the iron. So there is a formation of ring sideroblast there. And atransferinemia is absence of transferrin. So these are some of the important causes of iron deficiency anemia. Let's move on. Now see there, what are the clinical features or clinical manifestations of iron deficiency anemia? First of them is pallor. This pallor can be mild, moderate, or severe according to the extent of anemia. And we all know where to examine for the pallor. Always start with the palpebral conjunctiva of the eye, then focus on the palm and also the nail bed. You can also examine for other mucous membrane. Second important manifestation is pagophagia or pica. Pagophagia or pica. Now, pica or pagophagia means the child will develop a habit of eating non-edible substances like dirt, like mud, like paint. That type of habit is developed by the child. And this is considered as one of the very important manifestation of iron deficiency anemia in childhood. Pica, okay, eating up non-edible substance. If hemoglobin is less than 5, which is a severe anemia, the child will become irritable, child will become anorexic, means there is a loss of appetite, as well as there is problem in the heart, which may result in tachycardia, dilatation of the heart, and systolic flow murmur. These are called flow murmur, and these are usually systolic. So tachycardia is faster heart rate. Cardiac dilation, this is a hyperdynamic circulation. So over a period of time, the ventricle will dilate, especially the left ventricle. This is known as, okay, dilated heart. And systolic murmur, again because of hyperdynamic circulation, there is too much blood flow from the heart valve, resulting in murmur. Another important manifestation would be decreased attention span, decreased alertness, and decreased learning ability. Very, very important point, especially in school going kids. Now, the teacher notices this thing. The child is quite irritable. The child is not listening what the teacher is explaining. The performance in the school is going down. This may be one of the manifestation of iron deficiency anemia. Not only in those kids, even the college going uh, adolescent, for example, okay, or even the adult. If we suffer from iron deficiency anemia, this is one of the important manifestation. And one more thing here, when we start treating by iron, within no time, within 24 to 48 hours, and definitely within 72 hours, the attention span will come back. The alertness level will increase. And this is a very good response. And sometimes it is utilized as a diagnostic purpose of iron deficiency anemia as well. Another manifestation is atrophy of the tongue papilla and intestinal villi. So tongue papilla are atrophied. The tongue may look very smooth there, smooth looking tongue. And everybody know, okay, another important is koilonychia, spoon-shaped nails is called koilonychia. One of the very important feature of iron deficiency anemia. Those nails are also very brittle. Let's move on. Now, How to diagnose iron deficiency anemia? See there, we have already talked about the uh, overall investigation of anemia, the general anemia, isn't it? So there also we talked about. So let's revise this again. If you do CBC, the hemoglobin, hematocrit definitely decrease, and red cell count is also decreased because there is not much iron available for the synthesis. MCV, MCH, and MCHC all are decreased. We can add MCHC here also, okay? All are decreased. That's why it is known as hypochromic microcytic anemia. Regarding the RBC morphology or peripheral smear, we can see small size RBC, and the central pallor in those RBC are increased. That's what we call as hypochromic. There may be anisocytosis and poikilocytosis, different shape and sizes. Okay, poikilo means shape, aniso means size. Though it is quite a common feature in hemolytic anemia, but in iron deficiency anemia also it can be seen. Another one, there is increased RDW, or red cell distribution width, in one particular field under the microscope. What are the different shape of the RBC or size of the RBC, especially size? This is known as red cell distribution width. Some are bigger, some are smaller, some are normal size. Okay, so this is known as RDW. It is increased here. Now, if we go for reticulocyte percentage, it is normal or moderately increased. It is increased especially during the treatment process. Regarding serum ferritin, it is definitely decreased because this is the storage form of the iron. Serum iron level is decreased, no doubt about it. Total iron binding capacity is increased, and free erythrocyte protoporphyrin is increased because a heme is the substance where iron is bound. Okay, so there is some problem with heme metabolism which results in increased synthesis of free erythrocyte protoporphyrin. Okay, so these are some of the important investigation. Now, another important part of today's lecture is what are the sequence of event during iron deficiency. So in the beginning, what is deficient, and later on, what will happen? These are called sequence of event. Now see that. So in the beginning, there is decreased iron storage. And we know this decreased iron storage by doing serum ferritin analysis. And when it is decreased, we know there is decreased iron storage. Another important, part or place where iron is stored is the bone marrow. So if we do bone marrow analysis by aspirating or biopsy, then there is decreased bone marrow iron on Prussian blue stain. So these two are the important, uh, interpretation of decreased storage of the iron. Second sequence of event is decreased circulating form of the iron, which causes decreased serum iron level, increased TIBC, and decreased percentage saturation of the transferrin. These two things are connected with each other. If there is decreased percentage saturation of the transferrin, then only there is increased total iron binding capacity. And the third one, there is formation of microcytic hypochromic anemia, and that is known by decreased MCV less than 80 femtoliter, decreased MCHC, okay, and high RDW. Now, to make it easy for you, let me give one more explanation here, a rather bit of example. Now, if we have enough money, we always deposit that money in the bank. Okay, we deposit that money in the bank. So if we understand like that, then this concept is very easy. Okay, so first of all, our bank balance should get decreased, then only the amount of money we have is going to decrease, and then we cannot buy certain things. Okay, or we are lack regarding the availability of money. So similar type of conditions occurs in the sequence of event regarding iron deficiency anemia. Now, what are the other findings of iron deficiency anemia? Already talked about this though. Okay, a bit of revision for you. Why it is repeated? Because they are absolutely important from the exam point of view. See there is epithelial atrophy, especially in case of Plummer-Vinson syndrome. Now, let me ask this question for you. What is the, what are the things which you see in Plummer-Vinson syndrome? Anyone?
Esophageal web.
Esophageal web. Esophageal web.
Esophageal web.
Dysphagia, iron deficiency anemia, and esophageal
There will
web.
be a
There is
difficulty in swallowing.
Okay, now you're right. Okay, different students are answering. Wonderful. There is a combination of the things because it's a syndrome. So it is very common in female. These female are having esophageal wave. Okay, they are having iron deficiency anemia, and there is a high chance of development of carcinoma of the esophagus, that is squamous cell carcinoma of the esophagus. Esophageal wave, iron deficiency anemia, and high chance of development of carcinoma of the esophagus. This combination is known as Plummer-Vinson syndrome, also known as Patterson-Kelly syndrome in some of the textbook. And in this condition, even epithelial atrophy is seen. Koilonychia, already talked about. These are concave or spoon-shaped nail with abnormal ridging and splitting, means they are very brittle. And pica, okay, or pagophagia is eating unusual thing or non-edible thing like a dirt, like a mud, like a wall paint, like biting of the pencils, okay, and things like that. That is one of the very important features of iron deficiency anemia. And if some children have this habit, then they can also suffer from lead poisoning. Remember that, especially paint has a lot of lead in it. Let's move on. Now, we are towards the end of this topic. So what is the treatment? The treatment is quite easy. So we just need to, supply ferrous salt. Oral administration of simple ferrous salt is the treatment here. And this is the dose, 4 to 6 milligram per kg of elemental iron in 3 divided doses. Remember, this is the elemental iron. Now, elemental iron is the absorbable form of iron which is available in those iron pills. It should be continued for 8 weeks after the blood values normalize. Some textbook even mention 12 weeks after the blood values normalize, or we have to give up to 3 months. The total, total treatment is up to 3 months. Now, let me clarify this once again. We have done the diagnosis of iron deficiency anemia and you have started treatment. After 1 month or 4 weeks of starting the iron, the hemoglobin will come back to the normal. But don't stop it there thinking the patient is all right now. You have to, okay, you have to replenish all that iron store which is emptied inside the body. So for that, I need to give 2 more months of iron therapy, in total 3 months or 12 weeks. Within 72 to 96 hours of iron therapy, there is peripheral reticulocytosis which is noted. And this is considered as a good response in the patient. See there, the reticulocyte count increases because the body is getting enough source of iron now. Response of the anemia to iron therapy serves as an important diagnostic and therapeutic tool. That's what I told you before. Sometimes it is a bit difficult for us to diagnose iron deficiency anemia. During that time, we can simply give iron to the patient and look for this response of the iron therapy. If there is a good response, then we think our diagnosis is correct. Blood transfusion is rarely needed and it is given only in severe type of anemia. Now, if you know what is the cause of this iron deficiency anemia, go for the treatment, like hookworm infestation. And which drug is given for the hookworm treatment? Which drug? Which drug is given for the treatment of hookworm infestation?
Albendazole.
Good.
Mebendazole, sir. Mebendazole.
Very good.
Mebendazole, sir.
There are different type of drug: albendazole, mebendazole,
Mebendazole.
exactly, pyrental palmoate. These are the different options for you. So any one of them can be given. Okay, albendazole is very commonly given in the clinical practice. Mebendazole is another option. Now, a bit of more information. What is the response to iron therapy? Within 12 to 24 hours of the start of iron therapy, there is replacement of intracellular iron enzyme or ferrous enzyme. There is subjective improvement, and there is decreased irritability as well as increased appetite in the child. And this is known as improvement after iron therapy. And every parent can see that improvement in their child, and they'll be very happy to see this improvement. We doctor can also utilize this as a success of our therapy. But don't stop it here. We need to continue iron for a long time. After 36 to 48 hours, there is initial bone marrow response, which is known by erythroid hyperplasia. Means there is increased RBC precursor inside the bone marrow. After 48 to 72 hours, the reticulocytosis occur and they get peaked at 5 to 7 days. Means the maximum level reached during this time. Up to 30 days, there is increased hemoglobin level and it will come back to the normal after 1 month. And we still need to continue for up to 3 months to replenish the iron store. Now, how to prevent iron deficiency anemia? What can we do? Okay, prevention is very necessary because we are talking about a pediatric age group here. Exclusive breastfeeding up to 6 months of age. Absolutely. We already talked about the importance of exclusive breastfeeding, and the amount of iron which is present in the breast milk has excellent bioavailability, so we don't need to worry. Weaning with food rich in iron. So weaning means what? What is weaning? Yes?
First food to the baby.
They first food to the baby, sir.
First food to the baby, sir.
Exactly. You're absolutely right. The first food, the first supplementation of the food which is given to the baby is known as weaning. Okay, so that should be rich in iron. Iron supplementation should be given to preterm and low birth weight baby though from the very beginning because they don't have enough iron stored in the body. Though they are exclusively breastfed, we have to consider iron supplementation in them. This is important one. Prevention of hookworm infestation can be done by deworming and wearing shoes all the time or slippers or sandals. Now, deworming means every 4 to 6 months, less than 5 to 6 year old child would be given 1 tablet of albendazole. This is very commonly done in the developing country. So let me repeat again. Every 4 to 6 months, okay, the children less than 5 to 6 year age are given 1 tablet of albendazole. This is known as deworming therapy. And if any hookworm or any other type of worms are there, then those will be killed by this deworming therapy. Shoes or slipper. If the child wears this all the time, hookworm infestation cannot occur because it has to penetrate the body of the child and goes to the circulation. So this is an excellent way of prevention. And another one is, we don't allow open field defecation. Open field defecation, which may be common in some part of the world. And that is another cause of hookworm infestation because the larva should be present in the soil. And how the larva reaches there? Because of defecation. So if we control these two things, then hookworm infestation incidence is very, very decreased. Another way of prevention is iron supplementation of adolescent girls. After they start to menstruate, this is even more important. even more important because they are losing blood every month and there is more chance of development of iron deficiency anemia. We need to fortify food with iron. Fortification means we add iron there so that those food will be iron rich food. That's the meaning. Okay, so at the end, these are the key nutrition messages because this iron deficiency anemia is a very important, type of dietary deficiency anemia. That's why, these key nutrition messages are, given here. Exclusive breastfeed for 4 months, if not possible for 6 months. Best is 6 months, but we already discussed this before. Practically up to 4 months is also fine. Introduce complementary food at 4 to 6 months, which should be rich in iron or they are iron fortified food. Lots of green leafy vegetables are given to the child. And time and again, meat is also given. Have vitamin C rich food along with the meal, like few drops of the lemon juice in food. That is highly desirable because ascorbic acid or vitamin C will enhance the absorption of iron from the diet. Avoid serving tea or coffee at least 2 to 3 hours before or after a meal because excessive intake of these things will decrease the absorption of iron. I am using the term excessive here. 1 or 2 cup while we take this balanced diet, doesn't matter much, but we don't give this type of thing if somebody is already anemic. Cook food in iron pot. This is another important way so that some of the iron may be available in the food. Okay, another one. So many important points are there. Okay, you can go through these on your own, but we have certain minutes left, so let me go through them. Include flesh food, means meat, different types of meat, poultry, fish, liver in the diet whenever possible. Some of the poor family, they may not afford it every day, but if possible, it should be there. Use fermented and sprouted food. This is a good, part of the balanced diet. Mix cereals and pulse dietary item, which may be a source of iron there. Limit the milk intake less than 25 ounces per day in 1 to 5 year age. This point I've already explained to you. Do not give excessive milk only to the child. Wash raw food thoroughly before eating and serving. Wash hand before eating because of high chance of worm infestation, and that worm will cause iron deficiency anemia. Not only hookworm, other worms can also result in iron deficiency anemia in the child because of decreased absorption. In preterm and low birth weight, we supplement iron from the very early age, and periodic deworming should be done every 4 to 6 months.